So if you break your arm, an X-ray gives you a really clean binary answer.
Really, you get that visual proof immediately.
Exactly. You see that jagged white line, the doctor points to the screen, and you know exactly what's wrong. It's visible, it's categorized, and honestly, that certainty is just comforting.
It really is. Yeah. But when a patient steps into a clinic with debilitating pelvic pain, that diagnostic certainty just kind of vanishes into thin air.
Yeah, completely disappears. We enter this landscape of vulval health that is historically murky, heavily stigmatized, and just incredibly frustrating for the people actually living through it.
And the clinic data we're looking at today reflects that frustration perfectly. I mean, we see patients enduring years of misdiagnoses.
Decades sometimes.
Exactly. They're told repeatedly they just have like a stubborn case of thrush or generic dry skin, or even that the pain is purely psychological.
Which is wild.
Right. And that happens long before anyone actually investigates the underlying physical mechanisms of what they're experiencing.
And that brings us to our mission for this deep dive. We are taking a massive stack of medical journals, NHS clinical guidelines, and specialist clinic data to answer one highly specific, deeply personal question.
Which is, does lichen sclerosus, often called LS, lead to dyspareunia?
Right, which is the clinical term for painful sex. And whether you are researching this for yourself, maybe trying to support a partner, or you're just fascinated by the complex ways the human body reacts to autoimmune conditions, our goal here is to demystify a disease that causes, well, profound silent suffering.
And the short answer to that question is yes. Lichen sclerosus absolutely leads to dyspareunia.
No ambiguity there.
None at all. But the medical literature makes it very clear that this is not simply a case of, sore skin.
Right.
What patients actually experience is this highly complex, multi-layered chain reaction. The condition triggers profound structural changes to the anatomy, a microscopic rewiring of the nervous system, and ultimately a severe psychological and muscular defense mechanism.
Okay, let's unpack this. Because to understand how all those layers interact, we really have to start with what is physically happening on the surface.
Yeah, the visible evidence.
Right. So for anyone unfamiliar with the condition, the clinical definition of lichen sclerosus is a chronic inflammatory autoimmune skin disorder, and it primarily targets the anogenital region.
So the immune system essentially gets confused.
Yeah. It mounts this localized attack on healthy skin tissue, which typically presents as these white, crinkled patches. The sources often describe the texture as looking like cigarette paper.
That's the classic description, yeah.
Yeah.
It frequently forms this 5-8 shape around the vulva and the anus.
So when we look at what that autoimmune attack is doing at a cellular level, we find the first mechanical cause of the pain, right?
Exactly. The chronic inflammation actually destroys the skin's normal collagen structure. So the tissue becomes incredibly fragile, it thins out, and it loses all of its natural elasticity.
It just can't stretch anymore.
Right. During the friction of intercourse, skin that would normally expand and glide simply cannot stretch. The physical tension causes it to split open, creating these micro tears that dermatologists call fissures.
It's like, think of an old rubber band that has sat in a drawer for years and completely dried out. When you finally go to use it and pull on it, instead of expanding, it just snaps instantly.
That visual captures the mechanics of the tearing perfectly. The skin has just lost its structural integrity.
But the fissures are only the beginning of the physical toll, aren't they?
Yeah, unfortunately. If the inflammation goes untreated over months or years, the body tries to heal those repeated micro tears. And it does so by laying down really dense scar tissue.
Which is called sclerosis.
Yes. Over time, that constant scarring physically alters the architecture of the vulva. The scar tissue can cause a condition known as introital stenosis.
Which is a literal narrowing of the vaginal opening.
Exactly, a physical narrowing.
But the sources also detail something called skin fusion, where parts of the anatomy actually disappear or bind together.
Yeah, it's really severe. The chronic scarring can cause the labia majora, the inner lips, to flatten out and eventually resorb into the surrounding tissue, or even fuse entirely to the labia majora.
Oh.
And more severely, the scar tissue can spread over the clitoral hood. It can fuse completely, effectively burying the clitoris underneath a thick layer of rigid skin.
Wait, that sounds incredibly painful just on its own, let alone during intimacy. I mean, does burying the clitoris just reduce sensation, or does it cause active pain?
Oh, it frequently causes severe localized pain, and that's due to the formation of smegmatic pseudocysts.
Pseudocysts?
Yeah, so smegma is just a natural buildup of dead skin cells and natural oils. Normally, this sheds away or is washed away.
Right, just normal bodily function.
But when the clitoral hood is fused shut, those cells and oils have nowhere to go. They get trapped underneath the scar tissue, forming this hard, inflamed pocket or cyst.
Oh, that sounds awful.
It is. Any pressure on that area, whether from tight clothing, sitting down, or certainly sexual contact, causes acute stabbing pain.
The reality of this is just staggering. So what does this all mean? If you are sitting there listening to this and you have been told that your pain is just minor discomfort, the literature completely validates your experience.
Absolutely.
The dyspareunia caused by lichen sclerosus is a literal physical blockage. It is acute tearing pain caused by fundamental structural changes to your anatomy.
And those visible changes, the tearing and scarring, they provide a very clear anatomical explanation for the pain. But what's fascinating here is when researchers looked closer, they realized the physical tears didn't fully account for the sheer, disproportionate intensity of the agony patients were reporting.
Because the skin fissure hurts, sure, but the pain scores coming out of the specialist clinics were just off the charts.
Right. To understand that discrepancy, we have to look beneath the surface at the invisible factors.
In reading through the journals, this is the part that really stopped me in my tracks. The research points to a microscopic shift in the actual neurology of the vulva.
It's incredible, really.
The condition doesn't just damage the skin, it actively changes the nerve density in the affected area, creating something called neurogenic inflammation.
Yes, when biopsies of lichen sclerosus tissue are analyzed under a microscope, researchers find an abnormal proliferation of subepidermal nerve fibers.
So those are the nerve endings sitting right below the surface of the skin.
Exactly. And what is crucial here is the specific type of nerve fibers that are multiplying. The tissue becomes heavily populated with fibers expressing CGRP and VR1.
Wait, CGRP and VR1, you lost me for a second. Are these like normal sensory receptors, or is the body creating something entirely new to deal with the autoimmune attack?
They are naturally occurring receptors, but they are completely overrepresented in this tissue. CGRP stands for calcitonin gene-related peptide.
Okay.
It acts as a neuromodulator that aggressively triggers inflammation and pain signaling. And VR1, which is also known as TRPV1, is a specific receptor entirely dedicated to transmitting the sensations of burning pain and severe itch.
So in healthy vulval tissue, you wouldn't see these specific pain receptors clustered together like this.
No, not at such high densities. But in genital LS, the localized immune response causes the body to hyper-innervate the area with them.
Wait, so the body's literally building a denser network of pain receptors in the exact spot where the skin is tearing.
Yes.
It's like taking a house's standard security alarm and upgrading the sensors to be so hypersensitive that, like, a gentle breeze blowing across the lawn sets off all the sirens.
That's a great analogy. The sensitivity is dialed up to the point where the nervous system is just screaming. This neurogenic rewiring is the missing puzzle piece that explains why the itching and the pain are so notoriously exaggerated in this disease.
The brain isn't just getting a signal that the skin has a small tear.
Right. It's receiving a massive amplified alarm from a hyperdense network of specialized pain receptors.
As if paper-thin, fragile skin and a hyperwired nervous system weren't enough of a burden, the sources highlight a third biological factor that often compounds this entire situation, right?
Yes, the hormonal overlap. Lichen sclerosus has what we call a bimodal age peak. It most commonly presents in prepubertal girls and in postmenopausal women.
And for that postmenopausal demographic, the onset of the autoimmune condition frequently coincides with genitourinary syndrome of menopause.
Commonly referred to as GSM.
Right. And GSM is largely driven by the natural systemic drop in estrogen that happens during menopause. Right?
Exactly. When estrogen levels plummet, the vaginal and vulval tissues undergo atrophy. The cellular walls become much thinner, and crucially, the body's natural lubrication mechanisms begin to fail.
The glands just stop producing the moisture needed to protect the tissue.
Right. So you end up with a patient whose skin is already under an autoimmune attack, it's prone to tearing, and it's hyper-wired to transmit burning pain.
And then you remove the natural lubrication that might have provided, a protective glide during intimacy.
It creates an absolute perfect storm of friction.
A completely hostile environment.
Incredibly hostile to any kind of penetration. But the deep dive into the literature reveals that the human body doesn't just passively endure this kind of repeated trauma.
No, it fights back.
Right. When the skin and the nerves are constantly broadcasting a 10 out of 10 pain signal, the muscular system steps in to react.
Here's where it gets really interesting, because what strikes me about the sources here is that the body's reaction goes far beyond just a dermatological issue. The condition essentially evolves into a muscular barricade.
Yes, the clinical term for this barricade is secondary vaginismus. Vaginismus is defined as the involuntary, painful contraction or spasm of the pelvic floor muscles.
And we differentiate between primary and secondary, right?
Yes, primary vaginismus is where a patient has never been able to achieve penetration. Secondary vaginismus develops after a period of normal, painless sexual function.
So in the case of lichen sclerosus, the severe pain from the fissures acts as the trauma that triggers that secondary response.
Exactly. The clinical data refers to it almost like a vaginal lock. It's the anticipation of the tearing.
So the brain remembers that amplified burning nerve pain, and before any physical contact even happens, the pelvic floor just involuntarily clamps shut.
Right, the muscles create a literal wall. It makes penetration not just excruciating, but physically impossible.
Wow.
And what is particularly challenging from a treatment perspective is that this muscular defense becomes deeply conditioned.
Because it's a habit now.
Yes. Even if a doctor successfully treats the autoimmune skin condition like the inflammation is reduced and the skin heals, the vaginismus often remains. The pelvic floor has learned to associate intimacy with severe trauma, and it continues to spasm out of protective fear.
I mean, if we connect this to the bigger picture, the psychological toll of living inside that loop must be overwhelming.
It is. The literature uses measurement tools like the Female Sexual Function Index and the Vulvar Disease Quality of Life Index. Across the board, patients with LS score incredibly low on these metrics.
Yeah, the emotional weight detailed in the specialist clinic data is just profound. Patients report struggling with severe anxiety, depressive episodes, and this crushing sense of isolation.
Because when intimacy, which is supposed to be a point of connection, becomes synonymous with agony, it places an immense, heavy strain on relationships.
There's the relentless fear of the pain itself, the guilt over the inability to be sexually active with a partner, and a devastating loss of self-esteem.
Which is only magnified when the architectural changes physically alter how the vulva looks.
Absolutely. So if you are listening to this right now and you have felt like your body is failing you or betraying you by locking up, the science shows it is actually doing the exact opposite.
Right.
This secondary vaginismus is a completely logical, physiological defense mechanism. Your nervous system and your muscles are teaming up to protect you from chronic injury. It's just that the defense mechanism ultimately causes its own deeply distressing kind of suffering.
And reframing it as a protective mechanism is so vital for removing the shame associated with the condition. The body is guarding itself. And the most encouraging part of the clinical guidelines is that this cycle, the fragile skin, the hypersensitive nerves, and the muscular barricade, it can absolutely be broken with the right medical interventions.
Which is great news. Let's pivot to that side of the research, reclaiming comfort, because the medical journals are very clear. While lichen sclerosus is chronic, the dyspareunia it causes is highly treatable if you tackle all three of those layers systematically.
Yes, the absolute gold standard, the undeniable first line of defense established across all international guidelines is the use of ultra-potent topical corticosteroids.
Like clobetasol.
Yes, clobetasol propionate ointment is the most commonly prescribed.
Wait, putting ultra-potent steroids on skin that is already paper-thin and tearing? I mean, that sounds incredibly counterintuitive.
Huh.
Won't a heavy steroid just thin the tissue even more?
It is the single most common fear patients have. And tragically, it prevents many from adhering to the treatment that would actually save their anatomy.
Really?
Yes. In a healthy person without an autoimmune disease, long-term application of an ultra-potent steroid can indeed cause skin atrophy. But in a patient with lichen sclerosus, the underlying disease is what is actively destroying the collagen and thinning the skin.
Ah, so the autoimmune fire is burning the house down?
Precisely.
Yeah.
The steroid acts as the water putting out that fire. It halts the localized immune attack.
Okay, that makes sense.
By stopping the inflammation, you stop the progression of the scarring. And remarkably, once the autoimmune attack is suppressed, the skin is actually allowed to regenerate.
It bounces back.
It does. It regains its normal thickness, its elasticity returns, and the fissures heal. Patients usually use the potent steroid to get the disease under control and then transition to a maintenance dose.
Like just using it a few times a week.
Right. Sometimes just a mid-potency steroid used a couple of times a week indefinitely just to keep the immune response quiet.
But what happens if the fire went unchecked for years before a proper diagnosis? If the architectural changes we talked about, like the fused labia, the buried clitoris, the narrowed opening have already set in, I mean, a topical ointment can't magically unfuse solid scar tissue, right?
No, topical steroids cannot reverse established rigid architectural changes. But this is where the clinic data point to some highly effective surgical and regenerative interventions.
Okay, like what?
For severe introital stenosis, where the vaginal opening is too narrow for penetration, surgeons can perform a perineoplasty, which is sometimes referred to as Fenton's procedure.
And what does that do?
This involves surgically dividing the scar tissue adhesions and functionally widening the opening to restore normal anatomy.
Got it. And the sources also detail some fascinating cutting-edge regenerative therapies being used for the scarring. One that really stood out is nano-fat grafting.
Yes, that's a brilliant approach.
They extract a small amount of the patient's own fat, usually from the abdomen or thigh, and process it to isolate what's called the stromal vascular fraction.
Right. And the stromal vascular fraction is essentially a highly concentrated cocktail of the patient's own stem cells and vital growth factors.
So when specialists inject this processed nanofat directly into the scarred, fused vulval tissue, the results can be remarkable. But what does injecting stem cells actually do to rigid scar tissue? How does it help the pain?
Well, the stem cells promote angiogenesis, which is the creation of new blood
Oh,
vessels.
wow.
Yeah, it floods the damaged, oxygen-starved scar tissue with a brand new blood supply. And this regenerative process physically softens the rigid sclerosis. It restores volume to areas where the labia might have resorbed, and it vastly improves the pliability and elasticity of the skin, making intercourse comfortable again.
That is amazing. And the data also highlights the use of PRP platelet-rich plasma, which is sometimes marketed in clinics as the O-shot.
Yes, very popular right now.
They draw a vial of your blood, spin it down in a centrifuge to isolate the healing platelets, and inject that concentrate back into the vulvar tissue. The clinical studies show it significantly reduces the hypersensitive itching and the dyspareunia, sometimes providing relief for up to a year per treatment.
Both nanofat grafting and PRP are showing immense promise for restoring function and comfort without the need for invasive excision surgery.
Right.
However, the guidelines strongly emphasize that these regenerative therapies must be performed by specialists who have a deep, specific understanding of vulval dermatosis, not just general cosmetic practitioners.
Yeah, that makes sense. But if steroids, minor surgeries, and stem cell therapies are the proven clinical route, it makes me wonder about all the over-the-counter alternatives.
Well, the wellness market.
Yeah, exactly. If you scroll through social media or walk down a pharmacy aisle, you are bombarded with vaginal wellness products. Yoni steaming, pH balancing washes, rejuvenation creams. If a patient is desperate for relief from LS pain, are any of these a viable stopgap?
The clinical guidelines issue a stark warning regarding the unregulated wellness market. Patients with lichen sclerosus should strictly avoid these over-the-counter products unless specifically cleared by their dermatologist.
Really? Strictly avoid.
Yes.
Right.
The problem is the ingredient lists. Many of these feminine hygiene sprays, wipes, and creams contain benzocaine, which is a numbing agent, or various fragrant botanical and plant extracts.
And putting botanical extracts on an active autoimmune flare-up is a bad idea.
It frequently induces severe allergic contact dermatitis.
No, no.
Think about it. You have skin that is already micro-tearing and stripped of its protective barrier. Introducing complex plant chemicals or numbing agents triggers a massive secondary allergic reaction. We see patients in the clinic who believe their autoimmune disease is spiraling out of control, but a biopsy reveals they've actually layered a painful allergic response directly on top of the lichen sclerosus.
So you are essentially pouring gasoline on the fire while trying to put it out?
Exactly, exponentially worsening their dyspareunia.
What about the laser clinics? We see a lot of advertisements for vaginal rejuvenation using lasers to fix dryness and pain.
The medical literature is highly critical of using routine laser therapy for lichen sclerosus.
Why is that?
A fractional CO2 laser works by creating microscopic thermal damage to slow off the top layer of tissue, prompting the body to produce collagen as it heals. It might provide a temporary superficial feeling of rejuvenation, but it absolutely does not cure the underlying autoimmune dysfunction.
Right, the immune system is still attacking.
Exactly. Furthermore, repeatedly ablating skin that is already genetically predisposed to aggressive scarring is a massive, unproven risk. The consensus is clear. Stick to evidence-based medicine.
That makes total sense. So let's play this out. A patient finally gets the correct diagnosis. They diligently use the clobetasol ointment, and the inflammation disappears. The skin heals. Maybe they undergo a perineoplasty or nanofat grafting to fix the structural narrowing. Are they fully cured at that point? Can they go home and have pain-free sex immediately?
Often, the answer is no. Because even with the skin perfectly healed and the anatomy restored, we still have to address the third layer of the condition.
The muscular barricade,
Right.
the secondary vaginismus. The pelvic floor is still waiting for the pain.
Precisely. Resolving the dermatological issue is only part of the battle if the nervous system and the muscles are still trapped in that defensive loop. The pelvic floor must be actively retrained to understand that penetration is no longer a threat.
Which requires dedicated pelvic floor physiotherapy.
Yes.
The sources outline dilator therapy as a primary tool for this. And, I mean, it can sound intimidating to a patient who's been in pain for years, but the clinical approach is actually very controlled, isn't it?
Very controlled.
It's a gradual process of using size dilators, always paired with a high-quality, organic, glycerin-free lubricant to slowly teach the muscles to yield rather than spasm.
It is entirely about rebuilding trust between the brain and the pelvic floor. And in severe cases where the muscle spasm is so deeply entrenched that traditional physiotherapy hits a wall, specialists can actually intervene with targeted injections of botulinum toxin type A.
Commonly known as Botox, they inject Botox directly into the pelvic floor muscles.
Yes, it acts as a temporary paralytic. It forces those hypertense, locked-up muscles to finally relax, which breaks the cycle of the involuntary spasm.
Oh, that's brilliant.
It is. That window of relaxation allows the physical therapy and the dilator work to actually be effective. It is a vital tool for resetting the neuromuscular loop.
It truly requires a full mind-body rehabilitation. You need dermatology to quiet the immune system and heal the skin. You might need regenerative medicine or surgery to correct the architecture. And you need physical therapy to retrain the muscles.
It demands a multidisciplinary approach, yes. Understanding the complex mechanisms of this disease, like knowing about the CGRP pain receptors, understanding the secondary vaginismus, it arms the patient with the vocabulary they need.
It validates their lived experience.
Absolutely. And it empowers them to walk into a clinic and demand a comprehensive treatment plan, rather than just accepting another tube of generic cream.
So, to circle back to our mission for today's deep dive, does lichen sclerosus lead to dyspareunia? Yes. Through a brutal overlapping combination of fragile, tearing skin, hypersensitive nerve rewiring, and a defensive muscular lockdown.
But the overwhelming takeaway from the data is that it is not a life sentence. With targeted expert care, that cycle can be broken and comfort can be completely reclaimed.
The science is there to solve the physical problem.
It is. The bigger hurdle we face is often getting the patient to the right specialist before years of unnecessary suffering have passed.
And that leads to a final thought I want to leave you with today. We established early on that lichen sclerosus is incredibly underdiagnosed. The clinical data shows diagnostic delays averaging well over a year, often stretching into decades. But reading through the sources, you have to wonder, is this massive delay just because the disease is tricky to spot in a brief exam?
It's a fair question.
Think back to our X-ray analogy. When someone breaks an arm, the medical system trusts their pain implicitly. But what if the historical systemic dismissal of female pelvic pain has conditioned patients and even some doctors to quietly accept dyspareunia as just a normal part of life?
We see that all the time.
We are told it's just what happens after childbirth, or it's just a normal part of menopause, or it's just stress. It leaves you wondering how much needless, entirely reversible agony is being endured behind closed doors right now, simply because society hasn't normalized honest, clinical conversations about vulval health. We have to stop accepting pain as a baseline.
We have to trust the pain, investigate the mechanics, and demand better diagnostic certainty.
Let's fix the X-ray machines, so to speak. Let's shine a light on the murky waters. Thank you for joining us on this deep dive. We'll catch you next time.